extract a badly decayed lower third molar with curved roots. So on the initial radiograph, we look at the crown of the tooth. It's a fully erupted tooth. It has an amalgam filling with some decay under it. There is a distal curvature of the mesial and the distal root, and also the roots are narrowing towards the apex as well. The IDN canal, superior and inferior border of the canal, is not interrupted. I don't think there is any communication between the roots and the canal. So this case is quite classified as an easy or a low risk case. So if you look at the green line, that's where I'm going to do my gutter, and I get asked a lot of questions about guttering. Do we have to gutter for every erupted third molar? As a rule, you don't have to, of course. If you are in doubt or you're a beginner, it's better to, because the idea of the gutter is you want to remove some of the cortical bone buccal to the tooth, where you can get into the cancellous bone, so you get some movement of those roots into the softer bone. So if you're in doubt, open a flap and gutter until you have more experience in hand. So in this case, we are going to section it. We're going to do an LS section, and we're going to separate the mesial part from the distal part. I did a few mistakes during this video that I will share with you. As a mistake, I should have elevated the distal root first and then the mesial root, but I was trying to elevate the mesial root and the mesial part of the crown, and of course there was some resistance because the distal portion of the tooth was still in place. Then during the video, you'll see the mesial root was broken, and I had to retrieve the broken apical half of the root. So I'm happy to share this mistake with you and how I managed to correct it as well. So if you look at the red, that's when everything was removed. So I managed to remove the distal root and the coronal half of the mesial root, and I ended up with the mesial root still in place. So if you look at the green line, I used a special burr and a special handpiece to be able to access some of the bone in the forcation area. I removed some of the bone distal to the mesial root, and I elevated the root distally. And I will share with you how I got access to this area. Sometimes it can be difficult to see properly, but with certain tools you can easily and safely access it and remove it in a small amount of time. So this patient was just before the holiday season, and he had some infection. He had a bit of a limited mouth opening as well. The soft tissue was a little bit inflamed as well. So with my initial incision, I feel the external oblique ridge. I stretch the mucosa and I run my blade. I think I had to give him a little bit more of local anesthetic in this area. Another mistake here, I'm using my finger for retraction, and you can risk getting the nail into your finger or index finger easily. So please avoid doing this. So again, just stretching the mucosa, getting my incision deep into bone, so you know you're resting on bone. I extend my incision till the distal side of the lower six. I don't have to retract this area, but it just gives me more freedom to retract. Now, a very important tip, or a very nice tip, is to run your explorer in the sulcus, and this will remove any fibers attaching the gums into the bone, which will make the retraction much easier. So just running the explorer, removing any fibers in this area. Now with the retraction, you just firm control pressure against bone. You can use your other index finger to support your retractor or elevator. This patient had a bit of inflammation and infection in the area. Soft tissue was a little bit weak as well, so you have to be a bit extra cautious to avoid tearing, which will make stitching easier. So a bit of pressure and rotation against bone. So make sure you reflect the periosteum from the buccal bone so you can be able to retract properly and avoid any tearing as well. You're just reflecting or pushing against the periosteum. You can see the inflammation. Now I'm using a straight handpiece in 40,000 RPM with silane irrigation attached to the handpiece. So you start your gutter from the distal to mesial, so you have better access and you can see where your bear is running. How deep your gutter should be, as deep as you can start seeing bleeding coming from the bone. When you see bleeding, then you know you are in cancellous bone, which is a softer bone, and that's where you can get some movements from the roots. Ideally, the narrow suction should be on the distal side of the gutter. I remember in this case I had DA was under training, but with more, if she had a bit of experience, ideally she should place her suction on the distal part of the gutter. This will make things much easier for you when you're operating. So my gut should be deep enough to see bleeding from the bone, and should be deep enough so I can see the forcation as well. Here the case is vertical and fully erupted, so it's much easier to section and access and see as well. You always have to protect the soft tissue, the lips, especially if the patient is under general anesthetic. It's very easy to overheat your handpiece, which can burn the lip very easily. So always use your retractor to protect the soft tissues. So now starting the section from the forcation area, getting into the bulb chamber, and from the bulb chamber I will move apically and coronally. Something I'm not proud of is when I start removing or cutting through the amalgam with this handpiece. Ideally I should have got my handpiece out with more coolant. So your section lingually, you don't want to extend all the way until you section or separate the crown. You want to extend around 90% of the way, and just to avoid cutting the or cutting through the lingual plate or the lingual mucosa and injuring the lingual nerve. So now I'm using my 45 angle handpiece, high speed. Another mistake here, I should have turned off the high volume suction, the blue one, because it sucks all the coolant before it touches the bear. So ideally, I should have turned the blue suction off and just leave the low volume suction. That's another mistake I wasn't proud of, because you can see we're overheating the amalgam, we're overheating the tooth as well. So with this bear, it's called 700 triple XL, which is a very long shank bear. And what I like about this bear, because it's a long bear, the head of the handpiece is away from your field of vision, so you can access areas very easily and you can have very good visibility. So I will use it to retrieve the broken mesial portion of the root. So now I'm just cleaning away all those amalgam powder that was being cut earlier on. So if I go back on time and use this 45 angle high speed, I would have turned off the blue suction and just use only the small narrow suction. So now I'm just finishing off the section. Now I'm just separating the roots, the middle and this root. Now one mistake I did in this case, I should have elevated the distal root first with some rotation. I should have continued with removing the distal root first. But instead, I stopped for some reasons and I start elevating the mesial root. Sometimes we do mistakes, sometimes we can think in the wrong direction. I can't remember why I chose to do this. I can't think of any reason why I did that, except just it's a purely wrong decision. So now we have a lot of resistance from the distal crown and the distal root to elevate the mesial, and that's the reason why the mesial root will break. Another mistake, I rarely use forceps. For some reason, I don't know why, I just grab the forceps and I start removing the mesial portion, and again, that's when you can see the fracture of the root will happen. But it's good for you to watch how I will retrieve apical half of the medial root in a case like that. So now the medial root will break in this moment, and now I'm left with a half medial root and a full distal root, where it can be very hard to access. So now I'm going back to the initial plan, which I should have done this first. So basically some rotation on the distal aspects, and the root has a certain hook, and it will show you which direction it wants to exit. So we just follow the direction where the root is moving. So you can see it's moving in a certain direction. It wants to rotate towards the medial side or the mesiolingual direction. So there is a bit of rotation with my luxator. I use more luxators than coupons. I don't actually use coupons at all. So a bit more rotation. Just trying to get it off the hook. And you can see it's rotating and it's slowly coming out. Now I'm left with a mesial part of, or an apical half of the mesial root. And as I showed you on the initial X-ray, I will use my long shank high-speed burr. Now I turn my blue suction off so I can get better coolant, and I'm removing a little bit of the bone distal to the root, and just a very small point of application on the mesial side. So I'm just creating some space, and use the space to push the root from the mesial into the distal, following the curve of the root. If you use a normal burr and a normal handpiece, the head will be on the way and you won't be able to see anything. But if you have good magnification, good light, and you have this long shank burr, then you'll be able to see exactly where the burr is cutting, and you have a very good control. Your DA has to be very smart as well, so she's getting her small suction in and out all the time. If she leaves the suction just in one place, the water will start pooling in the socket and you'll be able to see properly. But if she moves her suction in, out, and in, out, then she is removing most of the water from the socket, and you'll be able to see and have good visibility. So just creating a bit of space on the mesiobuccal as well, so I can just put my narrow luxator in this area to push it towards the distal side. So here I'm creating some space. Just check with my mirror. So getting my straight luxator, kind of like in an oblique direction on the space I created on the mesiobuccal, and a bit of rotation, and now it's moving to the distal side. Has a bit of a hook or a bit of curve under it, so I might grab my crier and get from the distal side just to lift it up. So getting my crier on the forcation side and just lifting the root into a coronal direction. The root is out, and now we're just irrigating some side in just to clean any remaining fragments. Now I place only one stitch distal to the 7, and I can stress the importance of this one stitch distal to 7. If you avoid placing it directly distal to the 7, you can lose the attachment of the keratinized tissues into the 7. And if you lose this attachment, you are risking getting pockets in this area, and it can be very hard to clean as well. So get your stitch as close as you can to the 7. If the tooth was fully erupted, you're not aiming for a primary closure. You are aiming for approximation. Whether to place a stitch on the distal or the distal relieving incision or not, I prefer not to. I've been trained not to, and the idea behind that is to avoid getting your needle close to the lingual nerve or putting any pressure on the lingual nerve. I routinely just place one stitch, and I never had any issues with post-operative bleeding or post-operative complications. But you can see here is the keratinized tissues. It's getting nice and high on the distal buccal aspect of 7, and that's what you need for proper soft tissue health around this tooth. I've seen the mistakes where the stitch is placed a little bit more distant, and then this tissue will roll more apically behind the 7, and you lose this keratinized attachment. And it can be an ongoing perio problem in this area. Just a simple single interrupted. We're just aiming for approximation, no primary closure, and you can see that there is nice keratinized soft tissue. Now at the end, I'm using Marcaine It's a very good practice builder. It will give the patient a long-acting anesthetic for 6 or 8 hours after surgery. Another mistake, I'm putting my finger for retraction. It's a very bad mistake. Don't give it as a block because the patient don't like it. Thank you for watching the video. If you like it, please share it with your friends. Subscribe to our YouTube channel. If you're interested to attend our courses, please visit our website. Thank you very much.